All right, so we are going to talk about physics and quality assurance. The purpose of this talk is not to tell you every single detail about physics or what medical physicists do in the clinic, but just to give you kind of an overview and an idea of what it is that we do in the radiation oncology department. So just to set the stage a little bit, as you go through your practice, both as a physicist and as a physician, you are probably going to end up wondering how you know that the treatment planning system is calculating the dose properly. How do you know that the couch is moving to the position that it needs to move after you do imaging? How do you know that the machine is delivering the dose that you think it's delivering? All of these questions at one point or another will likely pop into your head. And this is what this lecture is meant to make you feel better about. So the learning objectives are for you to end up knowing how to describe the purpose of QA, what the different types of QA are in a radiation oncology department, and to just understand the general frequency of QA. Now, there's a couple of quotes on this slide about the purpose of quality assurance. Essentially, it is just a way for you to know that things are being done right in your department. That is the main goal. There's studies out there that show that there's a correlation between the patient outcome and the equipment that the facility has, how much technical support it has, and what the physician characteristics are. So you would think that there would be tests that everybody would run, that everybody would implement, that would make sure that every facility is at the same level, right? Well, actually, these tests, which would be kind of quality assurance driven, right, vary from state to state, and most QA programs are voluntary. So why would people choose not to do QA? Well, it is expensive to have a good QA program because it means that you need increased staffing, because it is not directly clinical work, right? You're not dealing with patients, you're not dealing with treatment planning, you're not dealing with all of those things that are directly impacting the patient. So you need additional workforce in order to be able to run these tests, and you need additional equipment. And the better your equipment is, the more efficient your QA will be as well. So all of this ends up adding up to a cost that's approximately 3% of the annual billing. So it is expensive to do things, but if you want things done right, you need to make sure that your QA program is implemented correctly. So essentially the incentive for all this, even though it is increased cost, is to really you should have the desire to practice really good radiotherapy. You're trying to make sure that your patients receive very good treatments, right? Very good quality of care, and quality assurance is part of what ensures that. Now, quality assurance is a very broad term, right? So when you think about it, you should kind of think about it having two umbrellas. There's the equipment and software, and then there's the clinical aspects. So you need to make sure that your machine is delivering the dose that you think it's delivering, that your treatment planning system is working correctly, that your CT scanner has an EDU calibration that is good for your treatment planning system and all that stuff. But it is equally as important that you make sure that your treatment plans for your patients are being reviewed by your peers as well, right? Everybody is likely to make mistakes every once in a while. There's a lot of patients that you're seeing, there's a lot of patients that you're treating, a lot of contours that you're doing. It is not uncommon for people to forget things here and there, or for people to have limited expertise that maybe one of their peers can help them find a better plan or a better technique. So all of this peer review is also a very important part of a good QA program. Essentially, everything that you do for quality assurance in one way or another relates to patient safety, right? And so these are the ACR Astro practice parameters. as they relate to patient safety. And as you go down the list, you can see that a lot of them either fall under the equipment and software umbrella or under the clinical aspects umbrella, right? So you need a treatment management system that can handle the prescription, the treatment parameters that you're going to use for delivery, that you can record the dose that you're delivering to the patient every day and keep track of that consistently and all that stuff. That is your record and verify system, which here we use ARIA, some other sites use Mosaic, but that's what that software is trying to accomplish, to make sure that you're not underdosing or overdosing the patient by delivering more fractions or less fractions that you're supposed to. Obviously, physics, one of the main tasks that a physicist has in a radiation oncology department is to make sure that the machines are calibrated properly. So that is what the second bullet point is referring to. The third one is talking more about the initial chart checks that we do. So when you have a patient that is getting planned for treatment, you have to make sure that the treatment parameters that you decided upon for that treatment delivery have transferred correctly to the treatment machine. And so there's a couple of different checks that we do that with. Physicists, during the initial chart check, will check the transfer of parameters from your treatment planning system to the record and verify system. The therapist will then check them again. So you will see that in a good quality assurance program, there are tons of layers, so that if something gets missed on one layer, it hopefully gets caught by the next. So there's redundancy, and that's also important. Same thing for brachytherapy. If you're not familiar with brachytherapy yet, I'm sure you will become familiar with brachytherapy throughout your residency. It's just a whole other type of treatment that we deliver. It's not external beam. It's just with an actual radioactive source that you insert into the patient. Then the other three last bullet points are all related to actual patient safety in the room. You guys have heard us talk about clearance a whole lot, and that is what they're talking about here, about preventing a mechanical injury to the patient. And then just common sense, good practice, you would want to both hear and see your patient, right, when you're treating them, because you're not in the room with them. So if you don't have audio and visual contact, you cannot treat, because it's not safe for the patient. If anything happens, you would never know until you open that door again, right? And finally, you absolutely want to make sure that you're treating the right patient to the right site. So you need to make sure that when the patient gets brought into the room, you use two different forms of patient identification. You want to use two, because what if the patient has the same name as another patient in the waiting room? You need to make sure it's less likely that they're going to have both the same name and the same birthday. So you need to make sure that you are ensuring that the patient that you're treating is the patient that you mean to treat. So in all this, where does the medical physicist come in? In every single one of the aspects that thoughtful person was wondering about at the beginning of the presentation. So when you see medical physicists doing QA, the typical traditional QA that you would think about, they are checking everything that relates to the machine and that relates to how that machine is modeled into the treatment planning system. They also check everything that has to do with the imaging equipment, with immobilization devices that you may be using for treatment, everything that relates to the quality of the treatment delivery at the end of the day is what the medical physicist is checking. And this is a very important point. So if there is a radiation oncologist who's having a bad day, that might affect one patient. If there's a medical physicist who's having a bad day and they miscalibrate the machine, that is going to affect every single person that's being treated on that machine. So it is very important that the things we do are done right. As far as equipment QA goes, there are three different levels. So the first thing that we do when we get new equipment is acceptance testing. So we're basically just checking that what they are claiming they're selling us is actually what they're selling us, so it performs to the standards and all that good stuff. For commissioning, we are characterizing that piece of equipment for the purpose that it's to have in the clinic. And quality assurance are just the checks that we do periodically to make sure that that performance is still what it's supposed to be. There are many different checks performed in many different schedules. Daily checks are typically going to be faster checks because, again, they're done every day, so you don't want them to take forever to set up. Just to make sure that the machine is working well, the tolerance is a little bit higher because the setup is a little bit looser, but it's just basically making sure that the machine is working how it's supposed to. Monthly checks, they're a little bit more thorough, so they are going to have tighter tolerances because the setup is done a little bit more carefully. And annual machine QA takes a really long time. It is tedious to set up, but it's because the tolerances are pretty tight, and that is when we check everything there is to check about the machine. Now, there's other QA that we do that is actually very patient-specific. So when you have more complex treatments like IMRT, VMAT, anything that requires the MLC to move a lot so that you can get a nice dose distribution to the patient, we have to check if the plan is deliverable. And the way that we do that is through patient-specific QA. Here we do it with the IROC check, which is a cylindrical array of diodes. There are other places that use different equipment. Nowadays, people tend to do it with the MV imager, with the portal dosimetry, which is really convenient because you don't have to set up an additional phantom, so it's really fast. But here we're still doing it with the IROC check. So you pull up the plan, you deliver it to the array, and you check that the dose distribution that the array is measuring is what you're expecting from the treatment planning system. And that is how you can feel better about the fact that the plan that you planned is actually deliverable to your patient. Now, obviously, this does not take into account the patient motion that we've been talking about up to now. So you know the machine is going to move the way that it's supposed to, but you still don't know if the patient is going to be in the position they're supposed to. So that's always something to keep in mind. I just wanted to run through common tools that are used in QA really fast. There's several detectors that we use. I just highlighted a couple that are very commonly used in this department. Ionization chambers are used for QA. TLDs and OSLDs, which I will describe a little bit more in the next slide, are used for patient measurements when we're actually doing the treatment delivery. There are many other detectors that we're not going to go into today. And then there are phantoms. Obviously, we cannot measure the dose inside of the patient, at least not currently, with the detectors that we have, because that would be really uncomfortable. You would have to be putting detectors in and taking them out, and nobody wants to do that. So we use phantoms instead. There are really simple geometric phantoms that look like cubes, and they look like cylinders, obviously not meant to mimic patients' anatomy. Then there's what's called anthropomorphic phantoms, and those are the ones that actually mimic the patient's anatomy more closely. So ionization chamber, just so that you have an idea of what it is, it basically is a gas-filled chamber that measures the ionization that the radiation causes in it as it goes through. TLDs, those are thermoluminescent dosimeters. So thermal is heat, luminescent means that it emits light. So essentially these detectors emit light when they're heated, and the amount of light that they're emitting is proportional to the dose that was deposited. And then OSLDs are very much similar to TLDs, only instead of being read with heat, they're read with light. And these are just examples of the types of phantoms that we use. Obviously, the simple ones are to the left, the anthropomorphic ones are to the right. And that is the phantom that we were seeing in the video that we just looked at. So aside from all this equipment QA, which is what you would traditionally think of a medical physicist doing, medical physics is moving towards having a more involved role with patients. So do not hesitate to contact a medical physicist anytime that you have a question along the way of the patient's radiation treatment at any point. We do see the workflow from beginning to end pretty thoroughly, and we are very familiar with the equipment, both the hardware and the software. So anything that you see that could be improved, please bring it up to a medical physicist and we can look at how to make it better. And there you go. Do you have any questions?